Welcome to another episode of Bite Back. Today we'll be discussing the different worlds of dentistry, cosmetic versus surgical. Same degree, completely different aspects.
So we both did the same degree, dentistry.
Came out of it, fine.
Yeah. Unscathed, somewhat. But we both do very different things day to day. So I thought it might be nice to share with everyone what our days look like, how we got to this point, what courses we did, what courses kind of shaped our careers. Why don't you go first?
Yeah, sure. Our days look very different, that's for sure. So, I'll usually have an all-on-4. Single implants. Sometimes I'll do some porcelain veneers or full mouth rehabilitations with single implants. It's never composite.
No.
It's never composite veneers. Don't worry about that. But
She can do it all.
I don't know about that. So essentially, I got out of dental school and I went to a clinic that pretty much focused on implants. So for me, I had to teach myself the cosmetic side because even implants, there's a massive cosmetic side to it as well. But I was watching my boss from 8 o'clock in the morning to 9 o'clock at night. So I would work my first shift and then he might have a general anesthetic with a surgery and I'd go nurse for him. So I definitely, like I said at the first episode, I definitely pushed really hard. But that's how I got into that area. And then I kind of realized, I actually really love this. I love taking teeth out, placing implants, and I was quite good at it. So I thought, well, let me explore it further. Took quite a lot of courses. I've been to Brazil, to be honest, too many more times than I'd like to say. Instead of holidays, I just go to Brazil instead and do courses. But it's been great. That's how I've gotten to where I've gotten to. Because in Brazil, you actually get to work on patients live. And it's not something that, you don't want to be practicing here in Australia. So doing that was great for me. I got to do implants and push myself with the next sort of pterygoids and palatal approach and zygos. That was great. But again, it's something that you have to invest in. And I have a lot of associates that come to me and say, can you just teach me? And I'm like, honestly, it's just so much better doing those courses because you're learning from the goats and you're getting to meet new people, but you're also getting to practice then and there. There's no point going to the courses, listening to theory or even listening to me talk if you can't physically do it.
Tell me a little bit more about Brazil. It sounds like you're making really huge investments in your learning and your training.
Honestly, loan for a house. That's how. And it's really important. I mean, one of the Brazil trips, I think, cost me like $40,000 to do. But you can't look at it as, oh my God, that's a lot of money. It's more that the investment that I made to upskill. Like I can now place pterygoids, which I think is really important. I do think that most all-on-4 surgeons need to be able to do that because it's your rescue, or you need to at least be able to offer it to the patients. So that, I would say probably the best course I took was Pedro's in Brazil because it just gave me so much in my repertoire that I can use every day. But then again, in saying that, you go to these courses, it's a week, you come back. You need to put it into practice. I see a lot of dentists, they go to these courses and they just forget to put it into practice. So I think that's really important, putting into practice when you get back. I've done soft tissue courses. Like I said, I did the Zygo course. That was another $30,000 to $40,000. And a lot of people go to me, oh my God, you spent so much money on courses. But
that's an investment.
It is. Yeah. It's an investment. Just like we invest in our bodies. We do massages or we go to the gym. It's investing in our minds. You can't just think you've done dental school because we didn't get taught any of this in dental school.
No way.
I mean,
no.
I don't know about you. I remember the first time I asked about an onlay, my professor laughed at me because if it wasn't a gold full coverage crown, it's like, I don't know who you think you are bonding a onlay. So implants, it was not taught. So that's something that you have to do yourself when you leave school. And again, people just think it's going to come to you. It doesn't. You've got to go out there and find it. Take these courses. Push yourself as much as you can and make that investment. I know when you start out, you don't have the money. We've just come out of dental school. But I would say that's one thing that is really important. And
probably wouldn't tell someone to do a $40,000 course the first year.
Maybe
out.
not. Maybe wait.
When you were doing them, you were a few years out already.
Many years out.
You were a little bit more financially stable.
That's fair.
In order to do these courses.
Yeah. But like I see a lot of, especially DB dentists, they really push themselves with the courses. There's a couple that I know that they do a course like every couple of months, which is great because they're learning and they're constantly pushing themselves. But yeah, it is a financial investment. that you have to make.
You'll end up getting that return anyway because you're able to offer more to the patient. So it does come back.
I agree. Like even like I said with all-on implants, it's called all-on implants, not all-on-4 anymore for a reason. Because you can't just make a patient fit what you know.
It's not cookie cutter.
Literally, that's actually the best way to say it. It's not cookie cutter. It's tailoring what we have and what we know to that patient. How am I going to do the best surgery that I can do with what I've got in my repertoire? And you need to have as much as you can. So that's why I've pushed myself and done more courses. I don't want to be that dentist that goes, oh, this is good enough.
And you want to be able to handle any situation as well.
That's true.
So whatever comes at you, you know, if you're looking at a CBCT and it looks like, you know, the bone's great, it's amazing, it's all going to go well, and then you actually get in there and the bone's really soft, how do you pivot in that appointment so that you can service the patient in the best way? Yeah.
Back in the day, that used to scare me like there was no tomorrow. But now I'm like, it's okay. Because I know I'll be able to fix it. So it's probably the same with you guys.
Financial investments, yes. The cosmetic courses probably aren't as expensive as the surgical ones. However, I have travelled overseas many times for different things.
You went and saw APHRA.
I did go see APHRA.
Not gonna lie, I really wanted to go just to
fangirling APHRA. Yeah, so funnily enough, when I was at university, I think my whole class followed him on Instagram. And Instagram was like it had only been around for a few years at that point. But we were all following him. Yeah. Him and Bloody Tooth Guy.
Oh, yes.
Loved them.
Both
of those accounts,
yes.
I was obsessed with.
Yep.
So the Bloody Tooth Guy made me fall in love with extractions, wisdom teeth, surgical, that I thought when I first graduated, I'm going to be a surgical dentist. Anyway, that was short-lived because I realised I'm better at the cosmetic restorative side. And then APHRA made me fall in love with the pros side of things. The veneers, transforming those smiles. So when he came out with his first course, and that was with Chris Coachman actually a couple of years ago, and it was in Miami, I was like, I've got to go to this. Like, this is like one of my idols. I need to be there.
Yeah.
So flew over to Miami, did the course.
Yeah.
Again, you've got your flights, you've got your accommodation. The course itself, it ends up being tens of thousands of dollars. Flew to Cambodia to do the implants.
Yeah.
So there's been a few times where I've actually gone abroad to do things.
Have.
But I find also you get great courses in Australia, so you can even fly to different states.
Well, I know like our own DB dentists are doing courses. It's good that we have it in Australia as well.
Yeah,
just to hear from everybody is, you know, how they do things. So, yeah, it's good.
So tell me, what does your day-to-day look like when you're planning these cases?
I always plan cases. Doesn't matter how many years out you've been doing it. I always say to people, plan to fail or fail to plan. And it just helps me feel confident in what I'm doing. So I always start with my CBCT planning. I have a free planning software. It's called Implastation. Honestly, like I think every dentist should get it. It's great. So any new grads I'm teaching, I always tell them, if you don't come to me with a 3D X-ray and a plan, don't come to me at all. I'm a little harsh like that, but it's really important. So I always start with that plan. Then my day might look like be extracting teeth, placing implants. If it is the all-on implants, then next day I'll do 3D printed try-ins. So patients aren't without teeth for more than 24 hours, which is great.
That's amazing.
I mean, how far technology's come.
So impressive.
I honestly never would have thought this. If you asked me 12 months ago, I was the biggest technology hater, but now I'm like, I love it. So you've got to adapt as well. So that's really great now that we've got that technology.
I see you guys using the iCam.
Oh my God, my favorite.
And the little dominoes, and you're there.
If I don't hear that noise, I'm like...
It actually looks so high-tech, and
It actually is, but you know the other day, it took me like 5 goes to get it. And I'm like, oh my gosh. It's like technology.
Sometimes technology can slow you down.
Yep.
So it's just like scanners and stuff.
Yeah, like what you used to take physical impressions, now you guys do scans. So same thing.
I still like physical.
Oh, you do?
I do. I feel I can get the margins, like really nice crisp margins with my analog impressions, but there's a time and place for scanners. I also find that the fit of the veneers is nicer with the analog, depending on which technician does the work and which lab does the case. So I'll pick and choose what I use depending on what the scenario is and where and who's actually taking care of the patient.
Fair enough. That's fair enough.
But the scanner, I find sometimes a bit like...
Yeah, temperamental.
It's temperamental, yeah.
Well,
But
same with the iCam, literally.
it can save you a lot of time,
Yeah.
but when it's temperamental, it's
Yeah.
yeah.
I think that's everything with technology. So then that's for the all-on-4s. Sometimes it includes grafting. Patients that have had missing teeth or the missing tooth, they want a single implant. It's been missing for ages. So we do the grafting and then might let it wait, pop the implant in the same day. There's certain, my day is just filled with taking teeth out, implants, and grafting.
So if someone was to say to you, I'm about to start learning implants, I want to get to the place where I'm placing all-on implants, where do I start? How do I start? And what pathway do you recommend?
So I always say start with pros first. Because that's how I started. So I'm bullish on that. I mean, I was doing pros for like 2 years before. So pros in terms of like placing the teeth, seeing, doing the impressions of it, the upgrades, seeing how that side of things works.
And are you talking pros for the all-on implants
Both.
or singles?
Both.
Yeah.
I think it's really important to see because if you don't see perhaps surgical mistakes that have been made, you can't then know, well, how could that have been fixed? So I think that's really important. After that, start placing your singles, raising your flaps, just starting with small surgical techniques. This is somebody that doesn't have any experience, right? So start with that, take teeth out. Make sure you're taking teeth out properly because there's a right way to do it and there's a wrong way to do it. I have so many patients that go to me, are you strong enough to take teeth out? It's really not about force. It's about technique. And that's what's really important as well going into implants. So taking teeth out, and then I would say start with the single implants. Restore your own implants because then you get to see, well, what mistakes have I made?
And how long should someone restore their own implants or place until, they're ready for the next stage?
That's hard to say. It depends. I'd say at least a year. That would be good because you're really confident, but it just depends on the person. And then after that, go and do some courses and get into the all-on-4 or all-on implant side of things. And it takes time. Again, it's not a sprint. It's definitely a marathon. But doing, like you said, the Cambodia course that you did, that's great because you get to place a lot of implants, get a feel for it, and then take it from there. Yeah. Now you, tell me about your day.
Once a patient says they want to go ahead with a plan, initially, of course, you've got all your full set of photos, you've got your OPG and your scan as well. You start with the smile design. So you get it to a point where you think, this is looking really nice. Send that off for the putty key and the flop to be made. Basically, get the patient in there, make sure they're nice and comfortable. I always start with the gum lift first or the gum recontouring because I find if your gums aren't great or the shapes of your gums aren't great, the rest of the work won't be great. So I'm really pedantic about my gum lifts and I'll often sit the patient up and take retracted photos to make sure that it's all nice and level. I'm that OCD with it.
I know. I've seen it. I love it.
Once I'm happy with the gums, then I'll start the preparation. And then, of course, I take my impressions, send that off to the lab, and I make the temporaries based off the initial wax up and design that I made. With those temporaries, then I get the patient back in about a week later. I find a week's a nice point. You can do a couple of days as well, but at that point, the gums have healed nicely. You can see nice shapes. Patients had some time to review the temporaries and review the treatment. They can give you some feedback as well. Make the adjustments according to what the patient thinks, but also I take control.
Yeah.
If I can see a cant, if I can see something, I'll correct it, even if the patient doesn't bring it up. At that point, we submit that to the lab, send the patient home with the temporaries, and then a couple of weeks later, the veneers will come back. I do a try-in, make sure they fit well, make sure the patient's happy with them. If they are, go ahead and cement that in. If they're not, we always send them back adjustments, put them back in the temps. But that's basically like my day-to-day when it comes to the porcelain workflow.
Can I just say, though, behind the scenes, how much, you guys, with the lab,
there's a lot of
correspondence?
Admin. Yes. Yeah.
Obviously, same with us. I know that, but the amount of behind the work that people don't realise.
I'm part of that many WhatsApp messages of that many different things. And you've got to stay on top of it because if you don't order things in time or if you don't communicate well enough and you get something back and the patient's going overseas in 3 days and you've got to cement them in, it'll be a big disaster. So you've got to be really good with the admin side of things, and it's a lot. You've got to be really organised.
But you're always I always say you're always looking at. I always see you take photos from your lab because you've got a really close relationship with your lab people. Like I always see you going, yep, photos, yes, okay, no, change this, change that, change this.
Yeah.
I'm like, oh,
Yeah.
wow.
I'm pretty like...
Great. It's the best. It's amazing. I love it.
And then with my composites, again, you do a little bit of planning for that, but I like to freehand mine. I have used palatal shells in the past, and I find they hinder me a little bit. So in my hands, it's not the easiest technique, but I like to do my composites freehand. And again, I like to place the two centrals first and sit the patient up and make sure that there's no midline cant, there's no like occlusal cant starting to appear, and I correct that, and then the rest of the kind of teeth follow. So I'm really pedantic with that, and I'll be sitting the patient up taking photos because it can't smile, so retracted ones work really well, and just making sure that everything's where it needs to be. Yeah. And then I spend a lot of time polishing them. Like the polishing, I probably spend like over half an hour just...
It's the most important part.
Making them look nice and shiny, because if they're not polished, you'll get stains. Yeah, so that's kind of my workflow with composites. Oh, and I love doing a little bit of ortho beforehand as well.
Okay.
So when it comes to ortho, same photo scans, whatever, and then you've got either your Invisalign, your Angel, whatever you're using, clear correct. You set the patient up and get the teeth straight, and then go into the cosmetic side of things.
Can I say, actually, we're talking so much about photography. Like, that is a really big thing I think I wish I had invested in early. Like, talking about investments and courses and all that, I think good camera.
Yes. Yeah.
I was using my iPhone. Like, I mean, I still use my iPhone for just the petty things, like not the things that I'm trying to learn from or take from my Instagram or whatever. But a good camera is like no tomorrow, because you learn from it.
Yeah.
I remember when I first started doing it, I was like, camera, like, what?
Yeah.
Like a photographer. But it's so important.
It's important, but also important for lab communication, especially when you're shade matching, having a good polarizer on it as well, having a good flash. Like, I swear, I don't even want to think about how much I've spent on my camera setup or on my loops, on my, all the other things, my composite instruments. Like,
True.
It's all another investment that eventually will pay its dividends back. Yeah.
Actually, I don't think about that. The loops. What loop magnification? You've got pretty high loop magnification now, don't you?
It depends. So I'll use, say, like a 3.3, I think it is. I've got two pairs of loops, 3.3 in one set. And then if I want to zoom in a little bit more, I've got a 5.7 as well. Yeah. I lean more towards the 3.3 because I like to be able to see the arch so that I can look out for cans, I can look out for, other things. Whereas I find if you're too magnified sometimes with this sort of treatment, it's very difficult to get everything. Yeah.
I agree.
Whereas the 5.7 is good for like endo, if you're doing like a deep cavity.
Yeah.
Yeah.
I'm the same. Like, when it comes to all-on implants, I actually don't really use loops at all when it comes to
I've noticed that actually.
Yeah, because I just feel like with loops you get too tunnel vision.
Too zoomed in.
And I need to see the whole arch. When it's more like perio, soft tissue or that, I do use it more. But, I mean, I've gotten used to not using them. But, yeah, it's just I want to be able to see more of the arch.
Yeah.
I'll
I notice
like,
all you surgeons do the same. No loops. And I'm like, how can you do it without a light, without, I'm so...
But we probably going to be like 30 years old, 40... Oh,
with a little hunchback?
Yeah, like this. And you'll be like this, sitting up straight. That's the difference. Let's talk about risks. Mm-hmm. Obviously very different. Surgical, there's a lot of medical risks that can occur. Mm-hmm. Cosmetic, there's also a lot of risks as well. No way would I ever say one's more than the other. I'd say the surgical is more of like I said, a medical thing. Yeah,
I would agree.
You need to be very, very diligent in terms of medical history and all that, and then even the post-op. You don't want to have infections. You don't want to have anything like that. So that's really some of the risks that we find day-to-day that we can see. We don't see it often, thank goodness, but it's something that we need to be very careful about. The antibiotics that I say to patients, you need to be on these because we don't want to have any hiccups. But what are the cosmetic risks? I mean, I do know them, but I like to hear as well from a cosmetic person because there's risks too.
So I would say cosmetic risks, I mean, there's biological ones, so such as gums, if you get recession, invading biologic width, so you get inflammation. So that's why your gum lifts and your gum recontouring has to be done well. Then there's also the risk of devitalizing a tooth, the risk of the patient losing the tooth as well. So preparations need to be as minimal as possible. But there's also the risk, it's more associated to the person you're treating, the risk of them not being happy with the treatment, or the risk that you might not see eye to eye, and there might be a little bit of body dysmorphia that comes out. So I think the more I've done this, the more I can tell if a patient, if I'll be able to deliver a nice job for the patient, or if I think that I'm not the person for this patient. But I think at the start, when I started, I thought I could do it all. I wanted to attempt it all. But now it's definitely not like that. You run into a few problematic scenarios, and it's usually associated with the person, not with the work. Because most of the time you can fix anything. If you invade biologic width, okay, you send them for a bone lift. If they don't like the veneers, okay, you change them. If they don't like the colour, you change them. If you get recession, that's a little bit harder. Most often, you could wait to see if you get
but there's things that we can do that we can perio gum soft tissue.
There's ways you can correct it, but when a personality is really difficult, that's when it becomes hard. So any small little detail, the case could be 10 out of 10 perfection. And I've had scenarios in the past where it's amazing and I think, oh my God, these are the best composites I've ever done. These are the best veneers I've ever done. And the patient will come back kicking and screaming, saying they're not nice or whatever. And you kind of think to yourself, well, how can I make this better when, they're seeing something completely different. So I think that's the biggest risk in cosmetics. It's the person attached to the teeth.
And we always have to remember that. And that's something that I do always tell people that I'm mentoring. You can't always make everybody happy. That's bottom line.
No, and you're not the best dentist for everyone.
Correct. And personalities, you need to get along with those people. That's why I always say to people, find a dentist that suits you. It's really important. We always listen. We want to hear people and what they have to say, but sometimes we don't match. Sometimes a person will be better seeing you than they will be me. And that's the reality. We shouldn't, I agree with that. Back in the day, I used to think I can treat everybody. But that's not the reality. And I think the more you do it, the more you realise that.
And you shouldn't take it to heart either. If someone doesn't choose you and goes to see someone else,
100%.
It's for the best.
Yeah, exactly. We've got different personalities.
Now, tell me, surgical risks, they would be a lot more extreme.
Yeah. I mean, probably worst, which I'm going to touch any wood that I physically can. When all of the implants failing and then having to do other techniques. For example, the cheekbone implants or the pterygoids that I was talking to you about, which is a big reason as to why I have gone and learnt how to do that, because you need to fix your failures. Well, at least when you get to that certain point, I'm not saying everybody has to, but get to a certain point where you go, well, I've done all this now. I want to be able to, in the future, when things go wrong, fix what has failed.
Or at least if you can't fix it, have someone that you're close with.
That's true.
Who can
exactly.
help. Yeah.
So I think that's probably the biggest risk. Patients, if you're not looking at their medical history correctly, that's another big, big risk for us. So we are always very diligent with that. I know all surgeons, especially DB, we are so, so diligent with that. And we're always in the chat talking and checking with the others, oh, hey, what do you think about this? What do you think about that? That's probably, like I said, the biggest failure is if you're doing a full arch, giving people back their teeth, and then after a couple of months, it not working.
Yeah, I suppose with all-on implants, they are coming to you for the last resort treatment. Yeah. And after the last resort treatment, there's not much more after that.
That's very true.
So anytime I consult a patient where there might be, in between, I would always try to push them towards trying to salvage and save their teeth. Yeah. So that they do have that,
Plan
last
B.
resort.
Yeah, I agree.
Yeah, plan B. Yeah. And a lot of patients are like, oh no, it'd be easier just to start fresh. And I'm like, listen, if you start fresh now, you've still got 40 years on this planet. Yeah. What happens
I agree.
if something fails in the next 20 years? What are you going to do?
And I have a lot of patients that come to me and go, oh no, I just want to rip them out and start again. And I'm like, it doesn't work like that.
Yeah. It's actually very common.
Very common. I think it's a misconception.
Yeah.
Especially with implants, the all-on implants realm, people just think, I have 25-year-olds. I just can't be bothered anymore. I'm like, oh, no. You need
we're not having this conversation.
Yeah, I'm like, you need to look after these. It's a commitment. You can't just think, I'm going to neglect my teeth and I'm going to neglect the next thing I get because...
Well, I find a lot of people will come with that mentality, don't want to brush and clean their teeth, and they don't realise that for all-on implants, you've got to take care of them as well.
Oh, yeah.
Yeah, so I sit there lecturing them no, you can't just let this fester and go gross. It's the same. You've got to look after it. It'll fail. If it fails...
Yep.
What are you going to do?
Correct. And most of the time it fails because the patients aren't looking after them.
Yes.
Or they're smoking excessively. They're not listening to our guidance. So that's when I find, honestly, if anything is to fail, it's because of that.
How do you manage those patients in those conversations?
Oh, yell. It's probably the hardest. Honestly, it's the hardest.
It's frustrating, isn't it?
It is, because sometimes I feel like a broken record. I'm like, please don't smoke. Please do this and this and this. And I can tell I know when people aren't looking after them.
Yeah, you can tell. You can always tell.
I can tell. You know, when I take them off.
I feel you can always tell.
Yeah. So, do you know what? This is a thing to everybody. Look after your implants and look after your teeth. But I can tell. And it's hard. Look, I mean, I'm a bit of a softie sometimes. It's my work going around. So I'm not going to have somebody, if an implant's failed, I'll usually just...
No, you've got to look after them.
I'll look after them.
But how do you set the standard with the patient of, this has failed because of X, Y, Z? Now, you know.
I'm pretty upfront with them. I tell them in the consult, I say to them, look, if you keep smoking, it is most likely going to happen. You know, most times it doesn't, because we are really good with our soft tissue management and all that. But in the cases that it does happen, I say, well, we did discuss this. And this is a risk that they were willing to take on and not change based on the advice that we gave them.
Do you ever get patients that still blame you?
Yeah, 100%. And that's something, again, I don't take to heart anymore. I used to, when things like that happened, I used to go, oh my God, it's my fault. But it really, like, implants don't fail without a reason. And if there is a surgical component and I go, oh, it's something I did wrong, I'll own it. And I'll say to the patient, look, that's on us. Oh, that's on me. But if it's on them, I'll say to them, this is something that you've done wrong. It's a hard conversation, but it's a conversation I think everybody needs to learn to have with their patients and be super honest from the beginning. I think at the beginning, when I first started, I wasn't honest enough. And I used to sugarcoat things because I was just trying to be really nice and be like, oh, it's okay. We can fix it. But you can't. Like, you really, like, there's times where you just, if it fails and it's gone beyond a certain point, we can't, like, you need to be really careful.
Sometimes you have to be so stern with them. It's almost like you're mothering them.
I know.
Yeah, and checking in and being like, are you doing what I've told you to do? And
I find that's probably still the most difficult part I find in dentistry, having those hard conversations. I think I need a coach on it. I need someone to coach me on how to do it because it's hard. You're very good at that, I would say. That's something that you've developed. Do you feel that it took some time?
I'm quite stern with my patients with what they, like, let's say if they're in temporaries, I'll give them like really strict instructions. Yeah. And if they come back with broken temps, I'll just ask the exact same questions. Yeah. Have you been wearing the mouth guard at night? Have you been cutting up your food, putting it on the back teeth? So it's really easy to determine what the problem is.
Yeah.
Most patients get it after a while, but you do have to be really stern and really but yeah, of course, if something breaks because of, let's say if I didn't check the occlusion well or I noticed something after, I'll say, oh, I'm so sorry.
Yeah.
I think this is why it's happened. Yeah. Let me fix that for you. And I always say to the patient, you know, there's a few different reasons why this could have happened. It's likely this, so let's correct that and see how it goes again. And I always try to keep an open communication with them. And I say, reach out to me in a couple of days if you're having the same problems. Like, I want to be able to correct it for you. Like, let's monitor this. Yeah. Most patients appreciate it because, again, you're there to help them and you're there to kind of, like, guide them through it. But this sort of stuff happens. Like, it happens, you know. And it's not, it can be the most perfect case and then something cracks or breaks and you're just like, okay, well, let's figure out why.
Yeah, I think that's really important.
Let's change that so it doesn't happen again. If it does happen again, it wasn't that. Let's look at something else. Yeah. And
you're right. These things do happen. And that's the part that everyone needs to understand. We're not perfect.
No.
Like, I think there's this misconception that we're perfect. I really think everyone thinks, well, it's going to be perfect every single time, but we're humans as well. And, you know, that's the part with women in particular, like mothers or things like that. That must be even harder. Like, I know for us, like, we get to go home at the moment and have a 10-hour sleep or whatever it is.
And chill.
But even for mothers, it must be even, like, you know, it's a really hard thing too because they don't switch off going home either. So,
and women often carry like more of that mental load, even, you know, going home, looking after, you know, their pet or whatever.
Yeah, that's true, yeah. I agree.
There is a higher mental load for them, so...
I agree. Yeah. Like my husband, I'll be like, oh, aren't you stressed about this and this? He's like, oh, no. I'm thinking, oh, okay,
all right. Didn't you see it? No, I didn't. And you're like...
That's nice. Must be nice.
Must be nice. Now I've got to mother all my patients, and I've got to mother the household, and I've got to mother...
So what's your opinion? Do you think people should venture out early into certain fields or get better at general, I guess. That's what I think. My take is get better at general first.
I think you have to be really good at general before you start delving into different areas. Like if you can't place a filling, why are you a dentist?
Yeah.
If you can't place a filling well,
Yeah.
the patient comes back to complain about the filling.
Yeah.
Like, what are you doing?
Yeah.
That's basically
but
a main role for us.
And I think it develops your hand skills.
Yeah.
It's the best way.
Oh, absolutely. And then I think through that, you will learn what you love and what you hate. Like I mentioned earlier in one of the episodes, I thought surgical was for me. When I was watching Bloody Tooth Guy and I started doing extractions at work,
Yeah.
everyone was referring their extractions to me. I was like loving it. But then I started doing the cosmetic, like a little dabbling in it here and there. And I was like, wow, I'm actually quite good at this. And then because I was good at it, I was like hyped to do more.
Yeah. You feed off it. Yeah.
Oh, I fed off that energy. Yeah.
We still
So
feed off that energy.
that's how I ended up down this path. Yeah, it was a complete change in what I initially thought I would be doing. Like I would have never thought I'd be doing this much cosmetics back then. I wanted to learn it, but I was like, no, I want to do surgery. But now I'm kind of dipping my toes back into that surgery aspect, which is really nice. Yeah. And it's been a really nice journey.
And that's so true. Like, so you do general, you get into the field that you like, you get really good. And to be honest, it gets to the point where it's like, I'm starting to do some composites now. I'm like, let me delve into it because you want to do something different. After a while, it does get
repetitive.
Yeah, I know it's scary for us to say, like, it's getting repetitive, but it is. And then you can delve into something else after once because your hands, I find out, like, my hand skills now, you can do anything. So that's why for me, at composites, it's like, well, it's just learning a different skill. But I really do think the general to start off with, then get into that area, and then after you can always go and do other things as well. That's what I'm finding.
Yeah.
You see that sort of that trend.
I think most dentists like to learn as well. So that's what I find. I've been doing restorative cosmetic, prosthodontics or whatever for so long, Invisalign, ortho, whatever, that I'm like, I'm actually not getting bored, but I'm like, I'm not being challenged anymore. Mm-hmm. So I'm like, what can I be challenged in? Okay, let's start learning single implants. I was restoring them.
Yeah.
I was restoring the all.
Yeah, you were restoring mine, yeah.
All on implants for you as well, and for, Dr. Tony. So I was doing a lot of that. But I was like, I need a little bit more.
Yeah.
Yeah. So I think for me personally, once I get to the point where I'm like on cruise control, I know I can add one extra thing to it.
We never stop.
So then I'm never on cruise control for too long. So I don't know if I'm doing a disservice to my stress levels and my mental health, but here we are.
But that's the thing. That's why we've kept pushing and pushing because it's a trait of ours. And I would say, like, it's a great trait. I do really think it's a great trait to keep pushing yourself because that's how you get to that next level. So that's the advice I have for the younger generation. Push yourself.
Sounds great. It's the advice I would have loved when I was a younger
I
dentist.
agree.
That's all we have time for today. As always, if you've got any questions, please leave them in the comments below. Scrubs on, doubts off. We'll see you next time.